Okay, so we'll go ahead and do our pediatric cardiovascular unit. To start with, we have our our learning outcomes. These are all going to be listed at the start of your book, and you can go through them on your own. So, the development of the cardiovascular system. Um, Around the 8th week of pregnancy, our heart is going to structurally form. We're going to form two atria, so our upper chambers of our heart, two ventricles, our lower chambers, and then heart valves to direct one-way blood flow. These cardiac vessels, the arteries and veins, they are going to form to transport our blood. Okay. So at this stage, our fetal heart is capable of circulating blood, but our gas exchange is still going through the placenta. Okay, so we are bypassing the lungs. So our right side circulation, I'm going to go ahead and click on the next page that shows us the picture. Okay, so our right side circulation, so over here, we are going to be moving deoxygenated blood from our right atrium to the right ventricle, and then that is going to pump blood into the pulmonary arteries towards the lungs. But whenever we're in fetal life, we are going to bypass the lungs, going to the placenta. Okay. Then coming back for our left-sided circulation, we are going to take our oxygenated blood from our lungs or placenta, depending what stage of life we are in, and returning it to the left atrium, flowing into the left ventricle, and then pumping out through the aorta, delivering oxygen and nutrient-rich blood to the entire body. Okay, so our cardiac cycle is driven by electrical conduction. These pacemaking nodes, so our SA node and our AV node, and we'll move throughout our myocardial muscle fibers. We want to know that our electrical activity that's measured on our EKG, that's going to be showing what our conduction system is doing. But we want to verify by our assessment that our mechanical contraction is occurring, okay? And we're going to assess this through our heart rate. So that's going to reflect our SA nodes activity and cardiac output, our pulse quality, so the strength and rhythm of our arterial pulsations, showing that our ventricles are contracting efficiently, and then our capillary refill time, checking our peripheral perfusion. Okay, we want this less than 2 seconds in children. And then lastly, our blood pressure, indicating the force of our blood against our arterial walls and helping us assess overall circulation efficiency. Okay, so signs and symptoms of hypoperfusion in our children. It's going to be prolonged capillary refill time greater than 3 seconds, a weak or absent pulse, any pulses that are faint or absent when cardiac output and blood pressures are inadequate. It's going to reflect reduced stroke volume, okay? And that'll show us poor circulation to our extremities. Pale or cyanotic skin color. This can be pallor, suggesting vasoconstriction and low perfusion, or cyanosis, so bluish colored, bluish discoloration. Already a decreased mental status. So in children, decreased mental status can look like confusion, restlessness, excuse me, or lethargy. Decreased urine output. So our kidneys receive about 20 to 25% of our cardiac output. So anytime we have reduced urine output, this is an early marker of poor renal perfusion. Cooled extremities. So when our peripheral vasoconstriction is shunting our blood more towards our core, leaving our hands and feet to feel cold and clammy. Hypoperfusion can look like tachycardia, so when our heart is sped up in an attempt to maintain cardiac output, and then hypotension. So in kids, hypotension um, our numbers are quite different than an adult. So in our infants, um, a normal systolic is going to be at 70. Children 1 to 10 years old, systolic, it goes by, so you take your systolic of 70, and then you're going to add it with 2 times the child's age. So my daughter, she's 9 years old, so you could say 9 times 2, that's going to be 18 plus the 70. So a systolic of 88 would be normal for her. And children more than 10 years old are going to have systolics 90 and above. Okay. So my point coming back to this hypotension is their systolics are much lower than adults, but when a child gets to hypotension, you're in trouble. Okay. Kids are good at compensating, and so they'll compensate, and then whenever you're at hypoperfusion, like what I was taught in my PALS class is they are so good at just chugging along, but once they reach that hypotension, that's whenever they've just kind of tanked on you. Okay, so and you need to be worried whenever you're seeing hypotension in a kid, but just be aware that the numbers are much lower for children. Okay, so moving on to our oxygenation. Oxygenation is our process of getting oxygen into the cells, okay? So we have hypoxia and hypoxemia. These are not interchangeable terms, okay? I'm probably going to say that a few times. But, okay, so our hypoxia is the state where there is insufficient oxygen. So we're at less than 90%. This can be acute and potentially life-threatening. So causes of this can be respiratory issues, circulatory issues, such as hypoperfusion, be from anemia, so just a low oxygen carrying capacity. But symptoms of hypoxia in children is going to be restlessness, confusion, tachypnea, cyanosis, and then in our very severe cases, a loss of consciousness. Okay, so this is going to be an urgent situation. We want immediate intervention. So that's going to be applying oxygen and airway support. Hypoxemia, that is abnormally low levels of oxygen in our blood. So this can cause hypoxia. Okay, so hypoxemia can cause hypoxia. We are measuring with hypoxemia our PaO2. Okay, so this is going to be measured through an arterial blood gas. Alrighty. Where was I? Oh, so fluid overload is going to can back up into the lungs, leading to impaired gas exchange, which is going to worsen our hypoxia and hypoxemia. Okay. Here's kind of another summary of the differentiating hypoxia from hypoxemia. Okay, and that is a graphic from your book. Okay, so a lack of adequate fluid can lower our blood pressure and increase our risk of shock in children. So we want to use our urine output as a major indicator of our heart function. Our kidneys are highly sensitive to changes in perfusion. So in our normal child, urine output should be about 1 to 2 milliliters per kilogram per hour. A decrease in output is going to signal a reduced perfusion, okay? So our fetal cardiac structures, looking at our fetal circulation, we have the patent ductus arteriosus. Okay, this is connecting the pulmonary artery to the aorta. So it is diverting the blood away from the non-functioning fetal lungs. After birth, this usually closes within hours. If not, it may take a few days, but it can cause heart failure and murmurs. The ductus venosus, that's connecting our umbilical vein to the inferior vena cava, bypassing the liver. So we are getting oxygen rich blood from the placenta straight to our heart and brain. Okay, this is going to close after birth, becoming the ligamentum venosum. And then lastly, there is our foramen ovale. It's going to be an opening between the right atrium and the left atrium, and that's going to allow blood to bypass the right ventricle and lungs. Okay, so that's just going to flow directly into the systemic circulation. This normally closes at birth as well. When we take that first breath, our right atrial pressure will rise. If this remains open, it is going to be called a PFO, a patent foramen ovale. Okay. Here is another comparison table that's from your book, comparing the fetal circulation with post-birth circulation. Alrighty, so our heart rate and blood pressures in children are a little different compared to an adult. Okay, we want to start our blood pressure checks on children around 3 years old. I have a table in the next, here we go. Here is our normals for our children, so their blood pressures as well as heart rate. What I want you to notice is that as our children increase in age, their systolic blood pressures start to rise as well as their diastolic blood pressures, and their heart rate will start to decrease. Okay, so see how we have our neonates with their regular systolic blood pressure between 50 to 75, regular diastolic 30 to 45, but their heart rate's going to remain high, 120s to 160s. You don't have to memorize any of these numbers. I just want you to recognize that as a child gets older, blood pressure starts to increase as their heart rate starts to decrease. Okay, so going through this again, heart rate decreases with age, BP increases with age. Measure blood pressure annually starting around 3 years old. And we want to ensure that we have our correct cuff size for this child's size. It's good to explain a blood pressure measurement to a child, letting them touch the cuff, explaining the cuff's going to wrap around their arm, it's going to squeeze. You can say it's going to be like a big hug that sees how strong your heart is pumping your blood. Okay, so just trying to explain it to a children can decrease their anxiety. Okay, so talking about the electrical system of the heart, our SA node, like located in our right atrium, that's our natural pacemaker. Okay, at the AV node, that's going to be our gatekeeper that slows this signal down. The bundle of His, that's our specialized pathway that's carrying our impulses from the AV node down to the ventricles, splitting into our left and right bundle branches. And then our Purkinje fibers are spreading that electrical impulse through our ventricular muscle. Okay. Whenever there's interruptions within this pathway, that is where we are getting our arrhythmias from. Okay. So key point I want you to know from this is your SA node should always be in control for a normal rhythm. If your conduction is disrupted, that's whenever we get arrhythmias. Okay. So on your test, you will be asked about EKG tracing. So I want you to be able to recognize what is happening at during the different parts of the conduction. So here at the P wave, this is going to be our atrial activity. So our hang on, I'm getting mixed up. Okay, so our PR interval, this is going to be shorter right here from the P to our R. This is going to be shorter in children just because their heart rate is going faster. Okay, we have a smaller R to R interval. Our QRS complex, so our ventricular depolarization. Okay, we have the QRS again. This is going to be narrow in healthy children. When we're repolarizing, so this ST segment and our T wave, that's going to be the repolarization. Our QT interval, so from here to here, oh, shows you down here as well. That can be shorter in our infants and children too, compared to adults because of the rapid heart rate. Sometimes some common pediatric EKG findings, we can have sinus tachycardia. This is going to be normal with our children whenever they're having fevers or any dehydration. We can have a sinus arrhythmia whenever they're having any variation with their breathing. Okay, so with inspiration, it can be a faster heart rate, expiration, slower, and then PACs and PVCs in children are usually benign. Okay, so we want to highlight the importance of our fluid balance and electrolytes and kidney function with our cardiovascular health. So anytime we have hypovolemia, this is going to cause a low preload, which is going to decrease our stroke volume, leading to hypotension. This can occur from dehydration, bleeding, any excessive diuresis, with issues where there's fluid overload, so hypervolemia, we're overloading the heart, and increasing that preload and afterload, such as situations with congestive heart failure. Okay, so the takeaway that I want you to have from this is we need to have careful fluid management in our pediatric population. Electrolyte monitoring, so we want to monitor our sodium, our potassium, our chloride, just looking at our electrolyte balances. So with low sodium, we can observe confusion, possible seizures in children, and too high, that could be situations like dehydration. For our potassium, high potassium, we can expect those peaked T waves, okay, and then lower potassiums can cause that U wave or PVCs in children. Again, our kidneys reflect our perfusion pretty well. About 20 to 25% of our cardiac outputs going through the kidneys. So anytime we see that falling urine output, we're going to take that as an early warning sign of low cardiac output and hypovolemia. Okay, and then again, your normal urine output for a child is about 1 to 2 milliliters per kilogram per hour. Okay, so we have several pediatric congenital heart defects, but we're going to hit the high points. We have our acyanotic defects and our cyanotic defects, as well as our obstructive lesions. Okay, these are going to adversely affect our health with the hypoxemia and the impaired tissue perfusion due to their heart failure. We want to make sure that we are taking a good, with data collection, a good health history. So risk factors, maternal risk factors can be infection, alcohol or other substance use, and diabetes So that's your maternal risk factors, genetic factors, history of congenital heart disease within family members, syndromes like trisomy 21, and the presence of other chromosomal abnormalities, okay? So for our general nursing care of a child with cardiac conditions, we are going to want to reduce any fatigue and discomfort. So we want to encourage frequent rest periods, try to cluster our care, use comfort positioning for these children. We want to provide respite care for the parents, make sure that they are taking care of themselves so they can take care of their child well, promote coping, encourage our parents to participate in any support groups. We want to monitor their daily weight, intake and output, measuring output. Sometimes for our neonates can look like weighing diapers, okay, watching for signs of fluid overload, so looking at edema, rapid weight gain, listening for crackles, and then looking at that abdominal girth. We want to evaluate for any developing complications. We want to let our providers know if we are seeing any significant changes, because, like I said a little bit earlier, their decomposition, they decompensate pretty quickly. Like they do well for so long, and then when they do decompensate, they just kind of really fall off that cliff, okay? So looking for the tachypnea, retractions, diaphoresis, okay? We want to make sure that we are using developmentally appropriate resources for the child's growth and development, using our dietitians to help with fortified feeds and supplementation. We want to teach our children, our parents, about their children's medications, how to take them properly, and what the medication is used for. Okay, so monitoring for coping with our children and families. Our social services and child life specialists in the hospital are really great resources. So our social services, we can use them to connect families with any financial, transportation, community resource needs. Our child life specialist, they're going to use therapeutic play and age-appropriate education to reduce fear for these children and help to teach them about their condition while maintaining a sense of normalcy with their life, and helping them continue with their school activities. Okay, so we want to make sure that our care plan for our patient and family is reflecting holistic care and being culturally and spiritually inclusive. Okay, we want to focus on our child's quality of life, not just disease management. Okay, so looking at our acyanotic heart defects, so this is where we're going to have a left to right blood flow shunting. That's going to lead to the heart failure. Okay, so left to right shunting is going to result in increased pulmonary blood flow from the increased pulmonary blood volume on the right side of the heart from the increased pulmonary blood flow. Okay, so we are going to have this patent ductus arteriosus, so the shunt between the pulmonary artery and the aorta not closing, a ventral septal defect. This is going to be our most common. It's going to be an opening between the left and right ventricles. And then the atrial septal defect is going to be an opening between the left atria and, left atria and right atria. Okay, so with our ventral septal defect, we can expect to hear a loud, harsh murmur, auscultated at the left sternal border. We want to look for heart failure symptoms, and many of these are going to close on their own, okay? They'll close spontaneously. Okay, the atrial septal defect, we can hear a systolic murmur. We can look for heart failure symptoms as well, and this can be asymptomatic. Okay, so our symptoms of CHF in our child are going to look like tachypnea, poor feeding, increased abdominal girth from that hepatomegaly, and then our patent ductus arteriosus, that is going to sound like a machine hum. Okay, so a machine-like continuous murmur, bounding pulses, widening pulse pressure. It can be asymptomatic. We can auscultate rails in these patients. But what I want you to know about a patent ductus arteriosus is how we treat it. And that is going to be with indomethacin. So that's an NSAID. And we use that with preterm infants to close the PDA. Okay, if it is stubborn, we can go in and close it surgically. Okay, so know that these are a volume overload problem. Okay, this kind of goes through it again. The patent ductus arteriosus, okay, left to right shunt, machine-like murmur, bounding pulses, widening pulse pressure, and we are using the indomethacin, which is an NSAID for closure. Okay, and then here we have a picture. Alrighty, our ventral septal defect, that is going to be our most common. Left to right shunt, we have a harsh murmur with that, and we usually have CHF symptoms if it is large, and that FTT stands for failure to thrive. The atrial septal defect, a harsh murmur as well, right atrial enlargement, and we would have mild CHF. Okay, for a management on this, we can use the diuretics and digoxin to help treat the CHF, and it can have surgical closure. Okay, I'm going to pause here for a second. Okay, so this is a picture of our ventral septal defect. Again, this can be closed during a cardiac catheterization or just careful observation for spontaneous closure. Okay. And then our atrial septal defect, again, can be closed during a cardiac catheterization. We can use diuretics for both the ventral and the atrial septal defect. Okay. A surgical procedure that can be done with this is a patch closure. Okay. So the acyanotic heart defect, so that's going to be the left to right blood flow shunt between the left to right blood flow shunt leading to congestive heart failure. Okay, so first up we have the aortic stenosis. So this is going to be constriction at or around the aortic valve. In infants, we can observe faint pulses, hypotension, tachycardia, a poor feeding tolerance. In older children, they may have exercise intolerance, exertional symptoms, dizziness, chest pain, and a possible ejection murmur. Okay, so non-surgical therapies that we can do with that is go in with a balloon dilation during a cardiac catheterization or administer beta blockers or calcium channel blockers. Okay, you may need the valvuloplasty or surgical options. For pulmonary stenosis, so we have a narrowing of our pulmonary artery or valve that is obstructing the blood flow from the ventricles. Okay, so with that, it has a systolic ejection murmur, so that clicking sound. It could be asymptomatic. Cyanosis varying with the defect, so worse with the severe narrowing. And then this child may have cardiomegaly or heart failure. So our non-surgical procedures for this can be the balloon angioplasty, and then with older children, the valvuloplasty as well. Okay, next is the coarctation of the aorta. So this is going to be a narrowing of the lumen of the aorta. That's usually at or near the ductus arteriosus. So that's going to result in the obstruction of blood flow from the ventricle. All right, so you are going to see elevated blood pressure in your upper extremities, bounding pulses in the upper extremities, decreased blood pressure in the lower extremities, possibly cool skin of the lower extremities, weak or absent femoral pulses. Okay, you may see dizziness, headaches, fainting, and nosebleeds in older children. Alrighty, so they can develop CHF symptoms as that PDA is closing. They can have the administration of the indomethacin, so that NSAID to allow for the closure, and they can also use diuretics. Okay, so here we have a picture of the atrial stenosis, the pulmonary stenosis. I thought I had a picture of the cardiac. Okay. So our cyanotic heart defects, so the right to left blood flowing, the blood flow shunt. So we have our transposition of the great arteries, so the great vessels of the heart are anatomically switched. Okay, so our aorta is going to rise out of our right ventricle, and the pulmonary arteries are going to come from our left ventricle. Okay, so this blood is going to circulate in two parallel circuits. So our deoxygenated blood is just recirculating systemically, and our oxygenated blood is recirculating to our lungs. Okay, so survival of this is going to depend on the presence of a PDA, a ventral septal defect, or an atrial septal defect. Okay, clinical signs is going to be severe cyanosis at birth, tachypnea, poor feeding, and a murmur. Okay, the tetralogy of Fallow, so that's going to depend on 4 defects that are going to cause mixed blood flow, and those 4 defects are going to be pulmonary stenosis, ventricular septal defect, an overriding aorta, and a right ventricular hypertrophy. So we're going to have cyanosis at birth with progressive cyanosis over the first year of life. So with this, there is what are called TET spells, and these are sudden hypoxemia during crying or feeding. Okay. So the management of these TET spells is going to be a knees to chest positioning. Okay, applying oxygen and administering morphine if necessary. Hypoplasic left heart syndrome is going to be an incomplete development of the aorta, aortic valve, left ventricle, and the mitral valve. Okay, so clinical signs of this is going to be severe cyanosis and shock as that ductus arteriosus closes. We're going to have poor perfusion in this child. Management is going to be prostaglandins to maintain patency, and then a staged surgical reconstruction for things. We have the tricuspid atresia. That's going to be the absence of a tricuspid valve, so there's no direct blood flow from the right atrium to the right ventricle. So the blood must flow through an atrial septal defect and a ventral septal defect to reach systemic circulation. Okay, so clinical signs of this is going to be cyanosis, tachypnea, growth failure, and a murmur. Managing this, we're going to use prostaglandins and then a staged surgery as well. So in all of our cyanotic congenital heart defects is going to involve deoxygenated blood bypassing the lungs and entering systemic circulation. Okay, this is going to lead to chronic hypoxemia, cyanosis, and risk of polycythemia and stroke. Okay, so again, talking about the transposition of the great arteries, we have this aorta and pulmonary artery connection switched, and we're going to use prostaglandins to maintain patency until surgical repairs were required. The tetralogy of Fallot, we have the four components: the ventral septal defect, the pulmonic stenosis, overriding aorta, and right ventricle hypertrophy. Clinically, these kids are going to have a murmur, failure to thrive, polycythemia, clubbing, and cyanosis, okay? The TET spells, I have a picture of the positioning. You're going to go knees to chest in a squatting position. Administer morphine if necessary, apply oxygen, and then they can have a staged repair of this done, staged surgical repair. Okay, so we have a picture, and then I think the picture of picture of the squatting position. Okay, so we have some of this repeating. That is the hypoplasic left heart syndrome, so underdevelopment of the left ventricle, aortic valve, aorta mitral valve. So we're going to have critical cyanosis when that PDA closes. Okay, and then the tricuspid atresia, so the complete absence of a tricuspid valve, so blood flow is going through an atrial septal defect and a ventral septal defect, depending on this PDA for survival. So we're mixing oxygenated and deoxygenated blood. We're going to have severe cyanosis. Okay, so management prostaglandins to maintain the ductal patency, and then stage surgeries. Okay, so in our postnatal circulation, we're going to have an increase in this pulmonary blood flow, functional closure of the foramen ovale at birth. Okay, that should be closing with when we start taking our first breaths, expanding the lungs. That pulmonary vascular resistance is going to fall and closing that flap of the foramen ovale. Okay, so an incomplete closure of the foramen ovale is called a patent foramen ovale, so a PFO. Okay, these are commonly asymptomatic. Ductus arteriosus, so the function in our fetuses is connecting the pulmonary artery to the aorta, diverting blood away from the lungs. So at birth, that increase in oxygen and decrease in prostaglandins is going to trigger constriction. So usually we have a functional closure of this in about 15 hours after birth. Okay, anatomically, it is going to close around 1 to 3 months. Our ductus venosus and umbilical vessels, those are going to close after our cord is clamped. Okay, so the clamping of the cord is going to cause immediate cessation of the flow. So closure time could be hours. Alrighty, so teaching point, I want you to know the foramen ovale, we should have a functional closure at birth, ductus arteriosus, functional closure at birth within hours, and then for our umbilical vessels and ductus venosus, closure after cord clamping. Okay, so obtaining a health history on our children, we want to be sure to ask about congenital anomalies such as Down syndrome and prior illnesses. Looking at maternal risks, diabetes, rubella, obesity, alcohol, and tobacco use. The infant signs of cyanosis with feeding or crying, suggesting inadequate oxygenation, a heart murmur, failure to thrive, poor weight gain from the increased metabolic demands. and diaphoresis with feeding. This is going to be a classic for the congenital heart failure in infants, okay? Clinical signs in our older children is going to look like fatigue and inability to keep up with their peers. They can have fainting episodes. That's going to be a red flag for an arrhythmia. And then chest pain, okay? And that can reflect ischemia and the severe congenital defects. Okay. Alrighty, so assessing these children, we want to get a full set of vitals, including their SpO2, do a pain assessment, auscultate heart sounds, listen for any murmurs, looking at signs of chronic hypoxemia, so cyanosis, clubbing, poor weight gain. Our CHF signs, we're going to be able to hear S3 and S4 possibly, have some hepatomegaly, auscultate crackles. We can observe tachypnea and signs of poor perfusion. Okay. Alrighty, so our interventions for these kids with CHF, we want to reduce the cardiac workload, so positioning this child in a semi-Fowler's position to decrease the respiratory effort, cluster their care, limit stress and crying episodes, use diuretics to reduce the pulmonary congestion and preload. Nutrition-wise, we want high-calorie formulas, fortified breast milk, small frequent feedings, and if necessary, placing a NG tube for feeding. Okay, cardiac procedures, they can have palliative procedures done to stabilize circulation until a definitive repair can be done. And then medications, I want you to know about the digoxin administration for kids. Digoxin, we're going to use this to improve contractility, decrease the heart rate, and increase cardiac output. Okay, so purpose of digoxin is going to be to improve that contractility, decrease heart rate, and increase cardiac output. We want to give this medication at the same time every single day. If the child is using a syringe to take it, we want to use a calibrated syringe, never a household spoon to administer this, and do not double dose if one dose is missed. We want to check their pulse for 1 minute, okay, and in a lot of infants, they may have hold parameters of a heart rate less than 90, or older children, it may be less than 70, but you don't need to know that since it's not a hard and fast rule. Okay. So our pediatric management, we always want to focus on symptom relief, okay? Nursing considerations for congestive heart failure, they're a lot like the congenital, so monitoring the same electrolytes, fluid status, looking for hypokalemia, watching for dehydration, and fluid overload, assessing for murmurs, extra heart sounds, the S3 and S4, any arrhythmias, changes from baseline, auscultating their lung sounds, listening for crackles, rails, wheezes, observing their respiratory work of breathing, trying to reduce the cardiac workload, providing rest periods, clustering care, minimizing stress for these children, and preventing crying episodes. We want to use supplemental oxygen when necessary, and then take daily weights for these kids. Okay, this is going to be one of our most sensitive measures of fluid status. So we want early detection of any complications through our monitoring of these kids. So diagnostic labs, or diagnostics and labs, okay, so prenatal, we can look at a fetal echo to detect any structural heart defects, do genetic testing, testing for chromosomal anomalies like trisomy 21, Turner syndrome, and the level 2 ultrasound that looks at a more detailed anatomy scan looking at structural anomalies that could indicate heart defects. Postnatal diagnostics, getting an EKG for these kids, detecting rhythm disturbances and conduction abnormalities, getting a chest x-ray to assess the heart size and pulmonary vascular markings, cardiac catheterization, although it is invasive, it's going to provide detailed hemodynamic data, looking at the pressures, allowing any interventional procedures as well, like the device closures and balloon dilation. Okay, labs that can be ordered. You don't need to know much about these, just that they can be. CBC is going to detect polycythemia or anemia, indicating the poor perfusion. Our CRP and ESR, that's going to be an inflammatory marker, looking for endocarditis, rheumatic fever, Kawasaki disease. Our electrolytes, we want to monitor the sodium, potassium chloride. ABG, evaluating oxygenation, detecting any hypoxemia. If we suspect sepsis or endocarditis, we may draw blood cultures. And then the ASO, that would be used for rheumatic fever. Okay, so our echo is always our gold standard, usually, for diagnosis. Okay, so our infants with congestive heart failure are at risk of delayed growth and development just because of the work needed to keep up with these metabolic demands. So they have this limited feeding tolerance, which can lead to a delay in growth. The inadequate oxygenation and perfusion is going to decrease energy available for growth, and just their low caloric intake overall. So we want to do good caregiver teaching, teaching that to do the calorie dense, small frequent meals. Dietitians are good at recommending a calorie dense formula. Okay, so with our growth in infants with congestive heart failure, it is not just about the nutrition, it's going to reflect the overall oxygen delivery, cardiac function, and energy balance. Okay, so nurses are essential for tracking these subtle changes. Again, kind of beating the nutrition, high calorie per ounce formula, short frequent feeds. We want to consider a modified nipple to help decrease the work of eating for these children, maintaining a semi-upright position. Okay. Teaching for the child, we want to teach the parents to try to cluster care and to teach them good soothing to limit the oxygen demand on the child. Daily weights, monitoring their intake and output, monitoring electrolytes and renal function, and we want to be culturally sensitive towards this family. Alrighty, moving on to rheumatic fever. So this is going to be an inflammatory disease that affects children usually from 6 to 12 years of age. We see this after an untreated group A strep infection. So it's going to primarily affect the heart, joints, skin, and central nervous system. So on your assessment, you may see a history of a recent sore throat, positive strep test. So our Jones criteria, or our major signs for this child, is going to be the carditis, polyarthritis, chorea, arrhythmia, and subcutaneous nodules. Okay. Remember the chorea, or those involuntary jerky movements. Interventions, they will use a penicillin to eradicate the strep. They may need prophylaxis continued for months. Anti-inflammatory meds like aspirin for the joint and cardiac inflammation. Bed rest, we want to treat the heart failure if present. Nursing considerations, we want to monitor their cardiac status, auscultating for murmurs, observing for signs of CHF like tachypnea, hepatomegaly, and edema. We want to complete all of the antibiotics for the strep infection and teach the importance of this long-term prophylaxis. Okay, so rheumatic fever is preventable. We want early treatment of strep throat. Okay. Kawasaki's disease, that is going to be a inflammatory disease affecting the skin, mucous membranes, blood vessels, and lymph nodes. Assessment of this child, we are going to have an acute phase where they can have a high fever that is unresponsive to antipyretics. Conjunctivitis, they can have a strawberry tongue, rash. Usually they'll have, they can have some unilateral cervical nodules. During that subacute phase, arthralgia, the risk of a coronary artery aneurysm formation. Convalescent phase, symptoms are going to resolve, but labs may remain abnormal. What I want you to know about Kawasaki disease, the intervention for this, okay? So high dose IVIG and then high dose aspirin. All right, this is going to be one of the few times that we're going to give aspirin to children, okay? And we're giving the aspirin for its role in preventing coronary artery complications. Alrighty, we want to do symptom management and then nursing consideration, monitor the cardiac status, monitor for complications, medication safety, again, educating the parents on this long-term low-dose aspirin use. Okay, subacute bacterial endocarditis, so we have an infection in the lining of the heart. Assessment-wise, the risk of cyanotic congenital heart defects, central lines, residual defects, and then rheumatic fever. Symptoms are going to be prolonged flu-like illnesses, okay? So looking for low-grade fevers, fatigue, any weight loss, night sweats, sheer flu-like symptoms. Nursing interventions, these kids are going to be on IV antibiotics for 6 to 8 weeks based on their culture and sensitivity, and we want to monitor for heart failure. And then nursing considerations, we want to teach the family to call ahead before any dental or invasive procedures, okay, for that prophylactic antibiotics. Alrighty, digoxin, again, checking the apical pulse for 1 minute before the dose. Call the healthcare provider if below the ordered set rate. Usually we're giving this dose every 12 hours. We do not want to double or make up doses and do not repeat after emesis. Toxicity signs is bradycardia, nausea, vomiting, poor appetite, and the yellow halo effect. We want to encourage people to rinse their mouth after the dose and keep the medication in a locked original container. Okay, so talking about those, like child safety, I guess you can't even see the bottles you have to push down into us. Okay, key takeaways. Congenital heart defects are going to impact the growth, perfusion, and development. Early detection is going to save lives. We have the different shunting directions depending on if we have an acyanotic or cyanotic. Nursing care, doing holistic nursing care, providing for the child mentally, emotionally, providing for the family, using or teaching good coping skills, teaching our families about their child's medication, especially digoxin, good nutrition, small, frequent, calorie-dense meals, and when to follow up with their primary care. Okay, so our practice questions. An infant with tetralogy of Fallot becomes acutely cyanotic and tachypnic during a blood draw. Which action should the nurse perform first? This is going to be one of those TET spells, so placing the infant in a knee to chest position. And then practice question 2, a child with coarctation of the aorta is being assessed. Which set of findings is most consistent with this diagnosis? The child will have higher blood pressure and SpO2 in the upper extremities rather than lower, okay, and weak lower extremity pulses.